All right, so we're going to move on to part 2 here, and this is a combined kind of elbow, wrist, and hand here, so it's quite a bit of information, but I didn't have enough elbow stuff to really go through as a separate package. So let's see how this goes. Okay, patient comes in with elbow pain. Anybody see anything abnormal here? I'm sure you do. I don't, but so anybody speak Italian? So this is like an eponymous injury of the elbow, right? Forearm, elbow. Or you can just, excuse me? Monteggia fracture, excellent. Okay, yeah, that's exactly what this is. And so there's a fracture of the proximal ulna here, and then there's dislocation of the radial head. Let's see on the other view here. So these kind of ring structures like the forearm and to some extent tib, fib, pelvis, you know, with if you have one fracture, you have to think about another one occurring at the same time. So if you look at this patient, this is the other Italian. Yeah, Galeazzi. Okay, excellent. So in this case, the fracture involves the radius. It's typically like the distal third or junction of middle distal thirds of the radius, and dislocation of the distal ulna. So they're sort of opposites. And I snagged this little table off the web here, mainly to remind you of this mental crutch here that I've used called Mugger, where the Monteggia goes with the ulna, and that's the fracture. So Monteggia, you have an ulnar fracture, and then the Galeazzi, you have a radius fracture. Okay, so that's one way to remember those things. Of course, like everything in orthopedics, there's subtypes of the different injuries, and we won't dwell on that because it's not necessarily that important, but you can have the radius displaced in different directions. Like, so this would be more anterior dislocation of the radial head. Here's a posterior. Here's a little bit more of a radial or lateral direction. And so, and then there's also this one has an associated fracture of the radius itself. So going back, so the Galeazzi goes with the radius. And then if you think about it, what bone's going to dislocate? Well, it's not going to be the bigger bone at either joint. So in the wrist, the radius is not going to dislocate as easily from the carpus. It's going to be the ulna, the small bone that dislocates at the wrist. And conversely, in the Monteggia, it's the small bone that's going to dislocate. So the radius is going to dislocate in the case of a Monteggia injury. What about this one? Patient like fell on an extended arm and comes in with a little bit of a deformity. Both bones dislocated, right? So they're both oblique views, really, but the bones actually look intact. Here's distal humerus. This would be like the region of the trochlea, capitellum, epicondyle here, and so the radius is overlapping. Ulna is also overlapping. So most often these elbow dislocations are posterior of the forearm bones, and it's not uncommon for them to have pretty limited fractures. If you do shear something off, it's often the coronoid process of the ulna in here that's kind of the last thing that keeps it from dislocating. All right. Let's see, what about this case here? So, one of the things you got to do when you look at elbow radiographs is also always look for effusion. So, does anybody see an effusion in this patient? Yeah, good. So you can see there's some lucency right in here. And try to zoom in on that a little bit. Do you see a posterior fat pad in this one? No, you really don't. Okay, so that's, you might be like on the bone board thinking, okay, well, I'm not really sure. That's not really that ballooned out. But of course, you have to look at the rest of the case too. So here's one of the views here. Looks pretty good. Don't see any definite fracture. What about this view here? Yeah, radial head fracture. So there is actually a fracture. It's not very displaced. It's this little line right there, and maybe it goes across like so. So the point of this case is partly to point out that if the elbow lateral view is oblique, you may be obscuring a posterior fat pad. Okay, so this is a little bit of an oblique view of the elbow. You can see the radiocapitellar joint is here, and then the humeral ulnar joint is here. And in the next patient, we had better views. So here's like a better true lateral view of the elbow where you have radiocapitellar joint, humeral ulnar joint. The condyles of the distal humerus should be almost superimposing on a good lateral. So this is like more typical of what you'd hope to see. Anterior fat pad, sail sign, and remember you can normally have an anterior fat pad in normal patients, but you shouldn't have that posterior fat pad, right? Remember, posterior is pathologic. And this patient just had a small buckling of the radial neck here. Same patient, I believe. This is just a little bit of a different point in time. Anterior fat pad, that sail sign, and just enough posterior that you can know that that's pathologic. So if you just see this effusion in the setting of trauma but do not see a fracture, what do we assume is present? Yeah, most commonly radial head fracture or radial head or neck, something that leads to an effusion in the joint. And of course, you can get an effusion just if you have rheumatoid arthritis or other causes of effusion, but in the trauma setting, you have to assume that there could be an occult fracture. This one is pretty obvious here, hopefully. You might be tempted to call this a fracture dislocation. And really, though, if you look at it, it's fracture of the distal radius, but the distal radius components are staying with the carpal bones. So in effect, what it is, it's really just a markedly displaced distal radius fracture where this whole situation should be up here. And one of the things to think about when you see fractures is, what are the possible complications? And so what type of complications might a patient get into if they have this much displacement of the bones? Yeah, kind of think of neurovascular injury, like, you're going to stretch your radial and ulnar arteries there, and could end up with ischemia. So the treatment of this is trying to get good timely reduction, just a close reduction initially to try to improve the alignment, to try to make sure you don't get into some neurovascular complication. Not that common with distal radius fractures because there's good blood supply and collaterals, but can happen. Okay, what about this example here? So different patient. And here I'm showing you pretty much of a lateral view of the wrist. We're going to look at that more in a minute on different patients, but what about the alignment of the distal radial ulnar joint? Yeah, it's separated. Yeah, and it's so here's the volar wrist, dorsal wrist, and here's the distal ulna. There's a couple small fracture fragments, like that's off the styloid. There's another little fracture here, but so this is a distal radial ulnar joint dislocation, and of course we just showed that Galeazzi injury, so you'd want to be carefully looking for a radius fracture, but you can in some situations have just a distal radial ulnar joint dislocation with fracture, like in this patient. Let's go back over to the slides for a second because I want to talk about one of the sort of trickier topics that we encounter, and it's important. So remember, in the wrist, you have in the PA view the normal alignment of all the carpal bones and You have these arcs of Galula that kind of define the alignment of the carpal bone. So smooth arc number 1 here, arc number 2 along the proximal aspect of the proximal row, and then the arc number 3 along the proximal aspect of this distal row. And so things should kind of line up in a good PA wrist like this. The lateral is perhaps even more important. And I just want to highlight this scapholunate alignment again, because when you look at a lateral view, you should always try to glance and say, is it a good lateral, like nice neutral lateral, where what should happen is the radial styloid should kind of line up with the mid-carpus here, and the ulna should overlap with the radius. But you want to try to find the lunate here. So here's this moon-shaped structure here. And then the scaphoid's harder to see. It's sort of peanut-shaped. It's in here. And the critical thing is this angle between the scaphoid and the lunate having to do with the coupling of those two bones together. So on this diagram from Greenspan, the lunate here, capitate, and the scaphoid. And so this angle between bisecting the lunate and long axis scaphoid, normally 30 to 60 degrees. There's also angles that are important between the capitate and the lunate, which we won't get into. But you want to look for this alignment in normals, because you can have a ligament injury that's otherwise not evident if you don't look at that angle. So in this radiograph, it's a little trickier than the cartoon, right? But if we outline the lunate here, it's like that. You draw a line bisecting it, and then you got to find the scaphoid, draw a line around there, and then you bisect it. And so this is the angle here that should be between 30 and 60 degrees. If you have what's called dorsal intercalated segment instability, you have an increase in the scapholunate angle, and you see here the scaphoid is about 90 degrees to the lunate. So normally those two bones are coupled together by the scapholunate ligament. If that ligament is deficient, like lax or torn, these bones can rotate with respect to one another and increase that angle. The opposite situation is where you have a decrease in the scapholunate angle. So here, actually the lunate's a little bit volarly tilted. So let me go back to this one. This is dorsally tilting of the lunate here. Here's volar tilting. And the scaphoid is now a little bit more linear relative to this lunate. So this is a decrease in the scapholunate angle. That's called volar intercalated segment instability. A lot less common than the DISI malalignment. But this one actually goes with injury of the lunotriquetral ligament. So let's take a look at a couple of cases like that. I kind of really set this up for you, so hopefully it'll be obvious. So in this patient, you look at the carpal rows, and it's a pretty good PA view, and you can see that you have to suspect a malalignment in this patient, because the spacing between the scaphoid and the lunate is a little bit wide, but we're not shooting right down the joint. You have two interfaces of the lunate here. But what's not quite normal is the lunate overlaps here. So that carpal arc, like second arc, is disrupted here. So that should make you suspect that the lunate is somehow malaligned. And if we look at the lateral here, can people see now after those diagrams that this is one of those DISI malalignment patterns? I see mostly nodding yes. So distal radius and ulna, pretty good lateral view. Here's the radial styloid process coming through there just to ensure that it's a pretty normal lateral. Here's the lunate, and it's tipped posteriorly, so that's dorsal tilt of the lunate. The scaphoid, the trickiest thing I think is that the pisiform can overlap here. So this is pisiform, but the scaphoid's like in here. So if we were to try to draw those angles, I'd take the lunate here and I would draw a line that bisects it like that. And then I would try to go either along the palmar aspect of the scaphoid, or I would try to bisect the whole thing. But I just go like along this palmar aspect, like right there. So that angle's over 90 degrees, right? So that's markedly increased. Different patient here. And so this is that opposite situation. So good lateral view. See the lunate is volarly tilted here and the scaphoid's here. So if we drew that scapholunate angle in here, you'd bisect the lunate like this. You'd find the scaphoid, go along the palmar cortex of it like that, something like that. And then so this would be the angle. I don't have the actual measurement, but it looks like it's decreased. And just going back to the other view on this patient, the PA view, you can tell, it could be that the wrist is in some sort of flexion or extension, and you have to be careful about that. But again, compared to that normal, you don't have very nice arcs of galula in here, okay? So you have to suspect a carpal malalignment pattern in that situation. Anybody see anything abnormal in this case? This is a different patient, comes into the ER, wrist pain, fell on outstretched hand kind of thing. Okay, so right, so somebody's wondering about the scaphoid, and obviously this is a scaphoid view, right? You can see that the it's centered up there more or less, and the patient's in some ulnar deviation of the wrist, which will help lay out the scaphoid. And so that's the scaphoid view there. Here's the other views here. So this view, and yeah, there's a lucency across here, right? So that's a scaphoid fracture. And the point of always showing these is that they can be pretty subtle. And in fact, we know that you can have really normal radiographs and just not even identify a fracture in this setting. So that's why we have the qualifier in our report saying to recommend follow-up films in 7 to 10 days if concern of scaphoid fracture. I have this one in here partly because you see the fracture pretty well here. It's not displaced. You don't see it so well on this view. It's probably across here. And on the dedicated scaphoid view, you probably see it maybe least well of all. So the point is, if you have dedicated scaphoid view and it looks normal, you can't use that to discount a lucency on the other views. This patient had follow-up. So that was, I think it's 9 days later. And just as routine follow-up, because we did pick up that fracture. And I just want to show how much easier it is to see that fracture after that time period, because what starts to happen is you start to get resorption along the fracture line as it starts to the healing response. So this is why if you have like a really subtle or occult one initially, and you wait about a week or 10 days, that you'll often see the fracture better. Now, why do we care about that? Well, a couple things, right? So you just don't want to miss fractures in general, but what complication can you get of the scaphoid if you have, if you don't identify a fracture and treat it appropriately? Yeah. So one complication is avascular necrosis, and what's another kind of general complication? Yeah, exactly, non-fusion, and those things could go together. So you could have AVN and non-union as well. So here's what happens if sometimes it's like a knucklehead patient that doesn't pay attention to their wrist and follow up. But so here's a scaphoid fracture that's like a chronic non-union sclerosis of the proximal pole. The margins of the fracture are real irregular in here. And so then this is a real problem for the patient because it's extremely difficult to get these to heal. You can't really get them to heal at all without doing surgery. And it leads to radiocarpal arthropathy. So you have malalignment. See the distal poles almost contacting the radius here. So that's that, and AVN leading to chronic wrist arthritis are the main complications, and high medical legal risk. This is a shout out to my outstanding colleague, Dr. Kate Stevens, who had this patient come through the emergency department or clinic with wrist pain. and show the views here. So here's a pretty good PA view. And things look pretty good, right? Good cartilage spaces. You have scaphoid, lunate. They're overlapping this second arc somewhat, but that can be just because of wrist flexion or extension. Here's a scapholunate interval. When we look at the PA view, let's just go through the bones here real quick, right? So as I hover over, you shout out what bone I'm talking about. Okay, here, scaphoid, lunate, triquetrum, and then there's one superimposed over that too. Pisiform, good. Okay, and then this one with the thumb. Trapezium goes with the thumb. Trapezoid, cavitate, and that one, hamate. Okay, good. So there's this thing in the hamate that's kind of sticking out as almost looks like a pedicle in the spine. What structure is that? That's the hook of the hamate, and it's a little bit like that coracoid that I showed earlier. When you see it on end, it can be tricky to diagnose anything with it, but you want to try to pay attention to it because people can injure that. So if I go to the lateral view here and zoom in, lunate, capitate, see the scaphoid in here, pisiform. And so this is the hook of the hamate sticking out like this, right? And what Dr. Stevens astutely picked up is there's a lucency across the hamate hook right here. So those can be very difficult to detect. They may just be radiographically occult, but it's another situation where if you are suspecting something and you don't see it, you can do either a CT scan or you can do an MR scan. And this patient happened to have had an outside MRI scan. So it's a nice example of a hook of hamate fracture. So here's axial T1 weighted scan and a fat suppressed T2 weighted scan. And so here you can see the hamate and the hook of the hamate here, low signal next to it, and on T2 you see edema on either side of it. So that is a hook of the hamate fracture. And these can be because of like a fall jamming the wrist somehow, or they can be from a baseball bat or a golf club chronically impacting in the hamate. So they can be kind of a chronic thing that comes up, or acute traumatic. And they're problematic because they can lead to non-unions and chronic pain. And some of the patients with these end up having the hamate itself, actually the hook resected, which people can get away with pretty well functionally. But if somebody's typing here, let me just pause for a second here and let me go to mute whoever's out there typing away. Let's try that. Okay, sorry, back to... Okay, so that's hook of hamate fracture. We're getting there. Here's another situation that comes in, patient in the emergency room. These radiographs are done. You know, you might worry about carpal alignment problem because the lunate's kind of overlapping here, but the question was really about the distal radius in this patient. You want to scrutinize the cortex of the radius, both volarly and dorsally. You look at this carpal alignment, actually the lunate's a little bit tipped back, scaphoid's in here. I don't believe there was really a carpal malalignment situation in this patient, but it's another situation where if there's suspicion of a fracture and you don't see it, it could be that MRI is helpful to diagnose an occult fracture. And so I wanted to show this example as well, because an MRI that was done a few days after that radiograph shows a nice example of a extra-articular distal radius fracture. So T1 low signal band across the distal radius, does not look like it goes to the articular surface. And on T2, lots of edema, okay? This isn't a real high-res wrist MR, but it shows, you know, if you look at the scaphoid and lunate here, the scapholunate ligament is proximal and it goes across here. And so on a T2 weighted scan, you should see low signal tissue connecting the scaphoid and the lunate. So if you had a high-grade tear of that ligament, you'd see fluid tracking through there. The lunotriquetral ligament's over here, and that's even tougher to see. So it could be that, you know, the surgeon knew or was suspecting a fracture of the radius and wanted to get a scan like this to confirm that there was no other ligament tear. This one doesn't window level very well, but if you look at this carpal alignment pattern, right, clearly pretty abnormal, right, because you have pretty good PA view, scaphoid, lunate, triquetrum, pisiform, and this lunate's like triangular in its projection here. So that's not normal, and so possibly could be a, you know, DISI or VISI thing, but it's more extensive than that. And so if you look at the lateral view here, which again doesn't window level too well, what do you see? Yeah, right. The lunate is actually markedly abnormal. So the lunate is here. Here's a little moon, and it's kind of facing forward. So the whole lunate is dislocated from that proximal carpal row. And there's different spectrum along these lines, from like partial or perilunate dislocation all the way to lunate dislocation. I didn't put it in here, but the lunate, if it loses all its ligamentous attachments, it can actually migrate quite a bit. So I have a different case that shows the lunate pops out. It's actually migrated well into the proximal forearm here. So that's a higher grade ligamentous injury, typically acute, and requires surgical fixation to get things to heal up.
In that last case, could you just talk about the mechanism of injury? Because it just seems odd that would be displaced.
Yeah, you know, I don't know a lot about the mechanisms in these, but they're, you know, typically it can be things like, you know, just markedly, you know, beyond range of motion, flexion or extension of the wrist. Sometimes these are associated with other fractures as well, like scaphoid fractures. So basically, it's a pretty high energy injury, but you have to have enough injury to tear both the scapholunate ligament and the lunotriquetral ligament, because those are the only things that are holding the lunate in place. And you know, but otherwise, I can't say that I know like what's a typical injury. Usually, these are patients that come into the ER with like motorcycle crash, motor vehicle crash, and you know, it's not like a typical, oh, just fell on outstretched hand, or you know, sports injury type of thing. Perhaps similarly in this case, this is a little bit of an atypical or less common injury, but if we look at the PA view, what do you see here? Distal radius, ulna, pretty good, right? Proximal row, pretty good. Nice alignment, no major malalignment. Distal row. Look at this carpo-metacarpal junction. Here's a different oblique view. But look at the lateral view in this patient. So, you know, we didn't focus on it on the normals, but the when you look at the wrist and the carpo-metacarpal junction, the metacarpals should all be lining up with the carpal bones. And in this case, there's dorsal dislocation of several of the metacarpals relative to the distal carpal row in here. So it looks like it's pretty hard to see on there. But the key on this PA view is you have overlap here, that, you know, between like capitate and hamate of like the third and fourth metacarpals. So those can be dislocated as well, and often associated with fractures. And again, a situation where we often will get CT scan to like further assess for the degree of fracture, malalignments, and so on. couple more cases here. So what about this patient? Comes into the emergency room with thumb pain. Zoom in here for you. Right, so it's tricky on here, but on this view and on this view, if I zoom in on here, there's this little bony fragment right here. And here as well. So that's a fracture of the base of the first metacarpal, and you need to be looking for how big that fracture fragment is. Does it go all the way through? Like typically this is going to be an intra-articular fragment because it's coming off the corner. You also want to look at the carpal metacarpal alignment here. So for the trapezium, first metacarpal base. And this is another one of these fracture situations that is eponymous, like people have named the fracture. So anybody know what the name of this particular one is? Not quite Gamekeepers. We'll look at something like that in a minute. Bennett's fracture. Very good. Okay, so you know, I can't remember these names myself that much. And what happens is if you start putting eponyms in reports, then often we disagree with the orthopedic surgeons. So it's probably better to be generic about describing things. Descripting, it's a new word. Don't put that in either. First metacarpal. So the Bennett's fracture is kind of just a corner fracture, intra-articular, and so that's a fairly simple one. The other one is the Rolando's fracture. And I used to remember that by like Rolando goes right through, like, you know, all the way through the base of the metacarpal here. And those are typically more kind of comminuted and Y-shaped. But Bennett's is kind of small, like maybe think of a baby fracture, and Rolando's are right through if you want to try to remember that for the minutia on boards. Let me stay here for 1 second. And so this is from this website, a Rolando fracture. So it's a bigger fracture. There's this component, and you can kind of tell that it's a rather Y-shaped injury. Both of these may be surgical, particularly the Rolando fracture. They'll surgically fixate them because they need to make sure that CMC joint is stable and the fracture's as anatomically aligned as possible to minimize the long-term sequelae. All right, on the last bit, we're running out of body parts here, so we'll just show these last couple cases. Oh, so yeah, sorry, I was jumping in. This is a different patient, or this may be that same patient's whole hand with that Bennett fracture here. So fracture at the base of the first metacarpal, and then look for how much subluxation there is of the first metacarpal base on the trapezium. Normally there's some flexibility there, and people can usually sublux somewhat, so it's hard to know how to interpret that, but it's good to look for that as well. This one, somebody mentioned this entity a minute ago. So this little fracture right there, I think it was Lewis. What did you, well, you didn't call it, yeah, it wasn't this case, but yeah, so this is fracture of the proximal phalanx base on the ulnar side here. And got to be careful because there normally are sesamoids that sit there as well. So like this may be a sesamoid here. But this is an abnormal fragment. Now this one may be subacute, but so what's important about this particular injury? Or what's the sort of mechanism that gives you this type of a fracture?
Breaking the neck of a pigeon.
Yes, when you're, you know, on your weekends off and you're out in the park and you decide to kill a pigeon.
Skiing is a good one.
Right. Or a crow or seagull. I guess traditionally it was some sort of game. But skiing, yeah, and it's like hyper abduction of the thumb or some forcible try to contract, you know, this, and you're tearing the in this case, you have a bony fragment, but it's along the ulnar collateral ligament of the thumb that can avulse off that that bony structure there. So here's the kind of I don't really like this picture, but showing, you know, very red, angry injury there where this piece of bone is pulled off by the ulnar collateral ligament. And, you know, we look at the ligamentous injuries more on MRI, but the bony injuries are important because they, again, they may need to be surgically fixated to get good healing. Okay, pretty easy case here. Right, dorsal dislocation of the DIP joint, no major fracture there. So how about this one? This one, actually, there's angulation here of the DIP joint, but it's not subluxed or dislocated. So it's possible this patient just had the finger in this position, but if they couldn't straighten it out, what would you be worried about? You have to worry about a tendon injury, right? So the bony analog of that injury is this one, right? So what, does anybody know the name of this type of a injury? There's like a dorsal ossicle, little fracture fragment off the dorsal aspect of the distal phalanx, and it can lead to a deformity. Often this is when somebody's trying to catch like a baseball or, you know, other ball, and it jams the finger directly and it forcibly palmar flexes it and avulses off that bit of bone. So this is mallet finger or baseball finger. So you can have a bony mallet finger or you can have a non-bony one. The first one with just that flexion would be where the extensor tendon is disrupted and you just can't extend the finger. And the second one with the bony fragment is the bony mallet finger, where in this diagram you can see how the orthopedist might repair it. There's a little bony fragment with the extensor tendon attaching to it and put in some K-wires to try to get that all reopposed. If it's treated non-surgically, you might just get it put in one of these extension splints like that to try to make sure the tissues stay opposed so it'll lead to healing. So I think that's the end of the tour on elbow, wrist, and hand as well. So I'll thank you for your attention on that and be happy to take any questions.